and today I'll be talking about the use of ventilators in the hyperbaric chamber. So this is with one caveat that right now our hyperbaric chamber is not quite critical care capable, so we're not actually treating ventilated patients down there yet, obviously. Otherwise you would all be aware of it. But I think as critical care docs, pulmonologists, this is something that you may encounter in the future, or this may pique your interest and maybe something you'd like to do down the line, because there is, as we'll talk about in this lecture, shortage of chambers that offer critical care hyperbarics. So no disclosures. The objectives will be, one, to highlight, look at the need for 24/7 ICU-capable hyperbaric chambers across the U.S. Some general logistics regarding treatment of critically ill patients in a hyperbaric chamber, as well as the use of the ventilator. What are the limitations in this different environment, and then some of the monoplace versus multiplace considerations. So I always like to start with a case. This is not my own personal case, but a case that some of my colleagues at UCSD, where I trained, they had this, and it was a 54-year-old gentleman, otherwise healthy. He was undergoing a routine endoscopy for this difficulty or this odd sensation in his throat that occurred after eating. The EGD went uneventful, and in the recovery in the PACU, noted to become hypoxic, bradycardic, and lost his pulse. CPR was initiated. EMS was activated. After ACLS was initiated, they did have ROSC. He was transferred to the nearest level 1 trauma center, intubated, stabilized, and sent for a head CT. Feel free to ask questions throughout the presentation, but a little audience participation. You see someone like this post-procedure, becomes unconscious, and undergoes cardiac arrest. At this point, what do you think is going on? Do you have any ideas that you'd like to throw out? And how would you proceed with your evaluation and management and the treatment considerations? I know, not a lot of history, but feel free to just throw out some ideas. Okay, so massive PE. Anything else? So big acute coronary, yep. That can precipitate certainly a cardiac arrest. Anything else? No? So what would be your next steps? I guess sounds like EKG. Any other treatment considerations, labs? You think this guy had a stroke? You want to push TPA? I don't know. Well, let's proceed and find out. So this was the initial CAT scan about immediately after the event, and you can see little pieces of air that aren't supposed to be there. There's predominantly on the right side. There's a little bit in the left side of the Sylvian fissure area as well. You can see on multiple different cuts, so you know it's not an artifact. So you see pneumocephalus on CAT scan. He was ultimately diagnosed with gas embolism and transferred to UCSD, the nearest 24/7 capable facility. And on arrival, he was seen by the stroke service, and he was intubated, sedated on propofol, and this is according to their neurologic exam from the chart. Had decerebral posturing, spontaneous non-purposeful movements of the hands and feet. His pupils were pinpoint, albeit he is on sedation with opiates. Reflexes were generally 2 to 3 plus. Borderline positive clonus at 4 to 5 beats, and extensors bilaterally and plantar. Keep in mind this is on sedation, so the neurologic exam obviously will be different off of sedation. But you can see very significant, profound deficits in this exam. So he was treated with what's called the U.S. Navy Treatment Table 6 with full extensions. This is a treatment table that's commonly used in the treatment of decompression sickness, or the bends. It's probably, with full extensions, 485 minutes, roughly. So it's about close to 8 hours of being in the hyperbaric chamber. This is followed by treatment table 9s over the ensuing days. Treatment table 9 is just your standard wound care table, 90 minutes of oxygen at depth and brought up. On exam of his ears, he did have barotrauma of the ears, T grade 3. So that's, it's out of a 4, and then 5 is perforation, so it's on the mid-grade. And eventually he's able to be weaned from the ventilator and transferred back to the rehab, to the previous hospital. This is Dan Popa, one of my coworkers at UCSD, in the chamber with the patient. And his neurologic exam just prior to discharge improved, awake, alert, following commands. He did have noticeable left-sided deficits, inability to cross midline with his rightward gaze. Nystagmus was present, basically hemiparetic on the left side, but can feel a little bit of sensation with a very nauseous stimuli. So this just highlights some of the features of gas embolism. This gas embolisms typically occur when there's a communication from some sort of source, and air source, and the vasculature. So you need some air to enter the arterial system directly. It can either one, enter directly, or two, enter through the venous circulation and arterialize. And that occurs either from shunts, so things like PFOs, if you can generate enough pressure on the right side of the heart to drive bubbles through, like Valsalva and such, or even venous spillage. So typically the lungs are a good filter for air bubbles. Typically they can tolerate a slow infusion of 0.3 cc's per kilo. Anything greater than that, the bubbles start to get stuck and cause inflammation or ischemia. Larger boluses can cause obstruction and even vapor lock of the heart, presumably like in this case, a large bolus of air precipitating cardiac arrest, typically over 3 to 8 cc's per kilo. In animal studies, dogs were able to tolerate 100 cc's of a large bolus, but over 300 to 500 typically passed away. Typical symptoms of gas embolism can be very, very mild. It all depends on the gas load. It can be very mild to frank cardiovascular collapse, and if it arterializes to the brain, cerebral arterial gas embolism, so coma, mental status change, encephalopathy, any kind of stroke-like symptoms depending on where the bubbles rest in the circulation, and seizure. In diagnosing AGE, imaging studies are not always consistent in defining and finding these air bubbles, and oftentimes actually in cases like the divers who get gas embolism, they're in the water, they get transported to the hospitals. Doing these CAT scans actually ends up delaying care and not getting them into the chamber quick enough. The scans typically can only detect macro bubbles, so 1.3 millimeters in radius. And again, depending on the finities of the scanner, if it's not a very thin slice, you might miss it on the thicker slices, again, because it's only a 1.3 millimeter radius bubble. These typically, when they arterialize, the bubbles don't stay in the system for a very long time. They say typically after about 60 minutes, the bubbles start to shrink and diffuse into the tissues just from the metabolic capacities of the body consuming the oxygen, and so the bubbles actually will shrink and continue in the circulation. So absence of air actually does not preclude the diagnosis, and at least extrapolated from divers, over 50% of the studies of the imaging studies of the divers who've had gas embolism are negative. No signs of barotrauma, no pneumothorax, no bubbles in the head. So it really rests on, you need a high index of suspicion, and it really rests on your history, your physical exam, looking at the risk factors associated with it, and timing these neurologic changes after or around procedure that is associated with gas embolism, such as we'll find out, endoscopies, central lines, your neurosurgery procedures, bypasses. We've had some of the TAVRs that have had gas embolisms here, and such. So this is just another case. I found it's interesting in the literature. This happened at St. Joe's down the street a couple years ago. This patient had a routine outpatient endoscopy. They found AVM in the duodenum that they ablated and also took biopsies of this. 2 hours after the procedure, he developed a progressive left hemiparesis, dysarthria, was transferred to the ER. This was the initial scan, and you can see obviously bubbles, but kind of low volume bubbles, just a few here and there. The rest of the story, the patient was actually unfortunately admitted to the floor service, or not according to their consultant recommendations, to the floor, where they ended up having a seizure and progressive mental status change requiring intubation, and then eventually got extubated and left with a left hemiparesis. But what's interesting in this scan, you can notice the bubble load isn't really that significant, but the scan 48 hours shows a dense stroke in the right parietal frontal areas. Albeit I did not see in the case report if they did an MRI or a CT angio to look for other causes, but presumably you have a neurologic change post-procedure, within a very short time window of developing symptoms, seeing a few bubbles on scan. I mean, this is a good example of this patient did not had a much greater volume bubble load than you see on the scan, and that's just because the bubbles circulate, they dissipate, and they end up traveling on out of the cerebral circulation. And these bubbles just cause such a profound inflammatory response in the endothelium, and so you get all these edema and cytokines that get released as a result of the injury. Question? Oh. So gas embolism after endoscopies, super rare. As of a case report I found in 2015, there's only been 18 documented cases. And the reason it's rare is because your bowel mucosa, it affords a very effective barrier against air and insulated gas penetrating into the circulation. And typically when you do these endoscopies, as all the GI docs will say, it's very low pressures. And if, for whatever reason, the pressures rise, you have multiple different egresses and exits and go down further into the bowels. You can come back up from where you're doing the procedure so the gas can escape. And the bowel mucosa is not typically opposed to very large venous collaterals or tributaries. And here's an example of, I found just 10 quick case reports, and you can see some of the risk factors associated or what happened during the endoscopy that in these patients that had gas embolisms. You see esophageal biopsy, gastric erosion, duodenal cable fistula, balloon dilation. One had esophagitis, ERCP after biliary stenting, PFO, with ERCP after biliary stenting, balloon dilation, and then another ERCP. And you can see that only 2 were treated with hyperbarics, and 1 left with paresis of just the left arm, and the other one died, unfortunately, from what was reported as septic shock after aspiration. But for the most part, you can see how debilitating it is, persistent vegetative state, and multiple deaths after the ensuing events. And so what are these risks, or why do these risks associated with gas embolism that are commented on this case study? Well, one, you need a pressure gradient to drive air into the circulation, so you have that with the insufflation of during the endoscopy. 2, you need a way to get into the vasculature. And so some of these different kinds of physiology or pathology will disrupt the mucosal barrier, so ulcers, peptic ulcer disease, inflammatory bowel disease. There have been case reports of people with Crohn's disease disrupting the mucosa and taking on air, sphincterotomies after ERCPs, biopsies, gastric erosions, and of course dilation, balloon dilations can of course disrupt the mucosa and cause vascular injury, hepatic injury. If you do these endoscopies in people with surgical procedures, so anastomotic repairs or like Roux-en-Y, sometimes if you enter into a blind sac, you can basically cause a ball valve and create no way for the air to escape, and so the lumen just expands and can be a risk of perforation or sending air into the vasculature. And in some physiologies or some surgical procedures, like varices or hepatogenostomies, it brings the bowel very close to large vessels. Treatment is typically supportive. Lidocaine can be considered. It's been well shown in animal models that with gas embolism and ischemia reperfusion, it does reduce intracranial pressures, brain edema, infarct size, and preserves blood flow as well as neurologic function, neuroelectrical function. In extrapolating to humans, the human studies for lidocaine in this setting have not been as not as robust, but it's definitely something to consider. And hyperbaric therapy is one of the mainstays of treatment for gas embolism. And all through the literature, it shows reduction in mortality, improvement in neurologic outcome. Typically, the earlier, the better. They say if you can get them in the chamber within 5 to 6 hours, you'll have the best bang for your buck or the best benefit. But there's been case reports of doing HBO as far out as 39 hours with a decent outcome. Yep.
Maybe you're going to mention this. Somebody had a case where one of our actually lung transplant patients had a cortis removed and then had loss of consciousness. And by the time they got the CT scan, there wasn't like clear air, but the syndrome was like, the suggestion was obviously that's what happened. And so I guess the question, we didn't really have a firm feel for this, is that do you have to see the air on the CT scan, or can you just have the syndrome and looks like an or they have a stroke, and then you still will benefit?
Yeah, I would say yes. If you have, again, like in the diving population, they only see it about 50% of the time. Depending on how quickly was the CT?
It was probably done within about 2 hours. So.
2 hours. I mean, even after 1 hour, you'll start, the bubbles will start shrinking. Like there's another treatment table 6A, where you press them to 165 feet, and that's to mechanically crush the bubbles, because the bubbles are big enough to cause ischemia. If you get them in quick enough, you can crush the bubbles to improve circulation. They say if it's out of an hour, the bang for the buck of pressing them to 165 feet is just not worth it, because the bubbles are already shrinking. So imagine by 2 hours, the bubbles are probably dissipated. There's some suggestion in the literature, maybe MRI might be able to find evidence of bubble disease using the different weights. But I think if you have...
Probably lose more time trying to do that.
Yeah, that's one thing. So if you have the clinical scenario, cortis coming out, abrupt loss of consciousness, neurologic decline, it's worth them to try and get them in the chamber as soon as possible. This is just getting back to the case. It's interesting, the endoscopy happened up at Palomar, San Marcos, and the patient was transferred down to UCSD, which is about a 28 miles or 36-minute drive. They did do a helicopter. Helicopter is another thing which is interesting, and things to consider is, if you go up into altitude, and I believe you'll hear an altitude talk next week, it can actually exacerbate bubble disease. But if you can stay low, I think it's below 5,000 feet, or you can even get into helicopters that are pressurized to keep them at 1 atmosphere. So that's just something to consider when you're helicoptering people out. But what's interesting is they flew 28 miles down to UCSD when there's a hyperbaric center about 4 miles away. It's an outpatient center, only 8 to 5. They don't do any emergencies there. It's a freestanding clinic. But you can just see the highlights. Like, wow, 15-minute ride, a 4-mile transfer versus sending them down 30 miles. It's actually, unfortunately, very much like our situation here. The chamber is not, unfortunately, critically care capable. Here at the DMC, 3 miles, 10 minutes. So unfortunately, we're all diverting all the carbon monoxide cases, any gas embolisms that are transferred. We'll just tell them to keep moving down the street. So I think that this highlights a shortage of critical care chambers across the U.S. and probably across the world. Martin et al. Performed a survey of hyperbaric chambers, and this is just in the Northeast. They used the website Hyperbaric link to find chambers on an online directory. They contacted about 180 centers, found that about 80% still offered HBO. 92% were monoplace, so fits one person. 8% were multi-place, fits multiple people. 18% were 24/7 coverage. 26 treated emergencies. 38% treated inpatients. We do inpatients here, but you're kind of stable inpatients that are on the floor. 20% could do cardiac monitoring. 22% were capable of having IV pumps to administer medications. 14% used ventilators. 55% were located within the hospital. 42% at a freestanding clinic building. 1% was a mobile unit. And so you can see that majority of these places are monoplace chambers. They typically treat outpatients, 8 to 5s, doing non-emergent dives. Only about half of them are located within a hospital. I mean, to perform these emergency procedures and be critically care capable, you have to be located in the hospital. I think, as I said, only about 14% do vents, and about 20% have the capable monitoring to do pressors and tele and all those invasive stuff. This is the website, Hyperbaric Treatment Centers. You can find Henry Ford there, and unfortunately it's up to date and no emergency services, but you can look it up if your training takes you elsewhere and you're looking for centers. This is a pretty good resource to start with. You can find what conditions they treat, staff, chamber hours, phone numbers, and in particular what services they offer, if they're 24/7 or not. And so what kind of patients who undergo hyperbaric therapy are actually requiring the critical care needs? Dr. Weaver out of Utah looked at a 20-year experience of his treating critically ill intubated patients, and he predominantly used monoplace chambers. He looked at it from 86 to 2006. In that period of time, he did about 182 patients, or 1,280 sessions. Those are about 60 a year, if it breaks down to. Predominantly male, 121 males. Median age was 44, but spanned anywhere from young children, age 2 to 83. The Apache score of 108 patients they were able to measure, get the data on, they found an Apache score about 17. They used about 3.8 IVs per session, and of 154 patients they had data for, about 27 died from their disease, their underlying disease, which needed the hyperbarics or from withdrawal of care. And I always have to calculate the Apache score, and you can see it's a combination of temperature, basically vitals, oxygenation, and lab-based values, and acidosis, and crit and such. And so he was treating pretty sick patients. Apache score 17 correlates to about 25% mortality, putting these people into the chamber. You can see the majority of the people he treated neck fash. Dr. Weaver is one of the gurus for carbon monoxide in the field. So he did a lot of neck fash, CO, crush injuries, gas gangrene, a couple of gas embolisms over that time, and then a smattering of mucor, acute peripheral arterial insufficiency, failing flaps, osteo, and radionecrosis. And this is just an example of someone with a neck fash needing debridement and HBO. What kind of complications did he encounter during treatments? Of the 1,281 sessions, about 35 had complications, so about 2.7%. 2 had cardiac arrest. 1 had suffered, unfortunately, massive gas embolism, underwent, in the course of the natural physiology, had acute lung injury, and as they came out of the chamber, there's a phenomenon of a post-hyperbaric treatment hypoxemia. Presumably, they say it's from, if you oxygenate the entire lung with 100% oxygen, as you come out of the chamber and come back to room air, all that oxygen you can metabolize, and it can precipitate transient atelectasis. And so in the setting of the acute lung injury, post-hyperbaric drop in oxygenation, they underwent a cardiac arrest. Another one had a VTVF arrest. And you can see that there were a bunch of basic mechanical or equipment malfunctions, ventilator circuit malfunctions, ventilator problems, arterial line and connector problems, and then a smattering of seizure, difficult sedation, arrhythmias, hypoxemia during air breaks. Typically during the treatments, we'll do periods of air breathing off of the oxygen to minimize the risk of seizure, and air trapping. So you can see in summary there's a pretty low rate of complications. Most of them are related to equipment malfunction, and some of these issues were able to be fixed quickly with just bringing them up, fixing the problem, and bringing them back down to continue the treatments. Hart et al. From, I believe he was out of UCLA, looked at 32 years of hyperbaric experience where he treated over 10,000 patients or sessions of patients in critical care units. And you can see some of the reasons that he opted not to treat them in hyperbarics. High FiO2 requirements, which was considered over 50%, requiring pressors, either vasopressors to keep blood pressure up or pressors to keep blood pressure down, vasodilators, sorry. Hyperthermia. Hyperthermia can lower the seizure threshold, and in the setting of giving boluses of oxygen, it can precipitate seizures. So high fevers was a reason to pause treatments. Status epilepticus. Tension pneumo, need for a fluidized mattress, morbid obesity. I believe our chamber limit is about 500 pounds, but there's also a circumference diameter, just like our CAT scans. End-stage malignancy, bang for your buck, you have to think about that. And at that time, use of TPN. So you can see that putting these patients into a hyperbaric chamber has its own inherent risks. You really need to weigh the risk versus benefit before putting them into this, unfamiliar environment where you just don't have access to these patients. Depending on what kind of chamber you use, in a monoplace, you cannot access them. You can just see them through the window, and all of your equipment is outside the chamber, for which you're dialing up the pressors and managing the vent. Inside a multi-place, you're actually in there with the patient, and so you can do some limited things, but it's a very confined space, as you saw from some of the pictures. It's hard to perform procedures at that depth or with all that noise that's happening, and in a tight area. You do not have access to an immediate crash cart. It's outside the chamber. You can't defibrillate in the monoplaces, and that's because of the 100% oxygen. It's possible in a multi-place. You can't bring the chamber up immediately if you're having an emergency. It takes, on a fast ascent, probably 3 to 5 minutes. And oxygenation is an issue, and we'll get to that. Some considerations for people who are ventilated. Makes sense. If you think of Boyle's law, pressure and volume are inversely related. So anyone with known pulmonary pathology will be at risk for pulmonary barotrauma. And those are particularly your patients with obstructive airways disease, COPD, asthma, active COPD or asthma exacerbations, bullous disease, having big cysts in the lung, creating air trapping. As you start the treatment, you compress those areas. You're breathing compressed air at depth, and as you're coming up, that the pressurized air can expand, and it's that expansion that causes barotrauma. And it's interesting, in animal studies, all is required is about 100 millimeters of mercury change or 4 feet of seawater. Upholding your breath from 4 feet to surface is enough to expand the lungs enough to make them pop. Other considerations is the oxygenation. They have used typically your UPTDs, or unit pulmonary toxicity dose, and this is defined as breathing 100% oxygen at sea level for 1 minute. That's considered 1 UPTD. They've calculated that just about over 860 UPTDs is considered your limit for your daily dose of oxygen, and that's about breathing 15 hours of 100% O2, and this is the reason we always bring down the FiO2 as quickly as possible in our ventilated patients upstairs. After they've done studies measuring the vital capacity, that after reaching that UPTD, you'll drop your vital cap by about 4%. You start causing denudement of the epithelium and the endothelium inside the lungs, and creating increased hypoxemia and worsening oxygen status. So generally, if patients are requiring more than 50% FiO2, we'll hold on treatments, generally because of the worry for increasing pulmonary toxicity. 2, if they're requiring a lot of oxygen, you switch them from 100% oxygen onto your air brakes during your treatment. You risk hypoxemia during the treatment. And also, as the amount of oxygen goes up that you're exposed to, your risk of seizure will also go up. These ventilated patients also can't clear their ears. So, like when you're swimming or in the airplane, you can wiggle your jaw, blow through your nose. So there is some incidence of rupturing their eardrums. Other considerations, if you have such severe VQ mismatch and hypoxemia from atelectasis, pneumonia, ARDS, right main stem intubation, creating these shunts, you might not be able to achieve the necessary oxygen levels in the body. Generally, they recommend at least be able to achieve a TOR of 1,000. If it's below that, consider refraining from hyperbarics until oxygenation improves. And the reason for that, I think, if you can't achieve a high enough oxygen, you need those high doses of oxygen to create angiogenesis, help your neutrophils, augment the neutrophils to help fight infection, improve collagen synthesis and fibroblast formations. And so how do you measure oxygenation in the chamber? There are some ways to do it, in particular would be interesting during your air brakes for your high-risk patients. Currently, there's no way to really measure your pulse ox at depth. They have considered using chest TCOMs, and TCOMs are basically these basically look like EKG probes that you connect typically in the wound setting. You put it around the wound to measure the peri-wound oxygenation. They say less than 30 is an indication for hyperbarics, and an indication that that wound will not heal with just the standard wound care. So extrapolating, you can put them onto your chest, measure the oxygen tension. It has a good correlation, about 0.8 to 0.99, but it's off by about 10%, but it's consistently off by 10%. So instead of measuring 100%, you measure 90, 95, it's 85, etc. And this is important because if you're experiencing hypoxemia during your air brakes, you may augment the ventilator settings, increase sedation, increase your PEEP. You can lower the depth of the treatment, all to preserve oxygenation. There's a lot of staffing concerns. You need a critical care nurse to help you during these chambers, to push drugs, manage your drips, etc. So they typically accompany the patient into the chamber if it's a multi-place. They need to be not just a critical care nurse, but a critical care nurse familiar with hyperbaric. So they need to be hyperbaric trained. It's like trying to, for your EMS people, I'll never be able to put an IV in on a bouncing EMS truck, but they can do it. So if you're trained in this different kind of environment, it makes things easier. So for that reason, you need a nurse on call at all times to staff a 24/7 chamber. They're not usually part of the routine dives. The routine wound care dives kind of run on autopilot. You need a doc capable of managing vents and critically ill patients. And then you need another person just to run for meds, labs, bring things to the lab and get stuff for you. And I think for most of these reasons, in the 90s, that's why Henry Ford closed the 24-hour program. It's to have someone on call 24 hours, ICU nurse, a doc, respiratory therapist to man the chamber, probably an extra hand to run for, go get stuff. It was just not financially feasible, and so they closed the chamber down in the mid-90s. The chamber itself, too, there's some logistical considerations. You need to be able to change the space to accommodate an ICU patient. So space for the gurney, the ventilator, the drips, all the pumps and equipment. You need to practice this smoothly in case an emergency shows up to be able to do it quickly. And simulations for these low volume, very high risk, high emergency situations, specific to critically ill patients as well as your ventilated patients. This is an example of the chamber UCSD. You can see there's 4 beds back there, and so you can fit 12. This is considered a multi-place. It's about this wide, and it's about 6 feet tall, so you can just barely stand in there. When you reconfigure it for critical care, you basically get rid of the first 2 bunks. You have all your equipment there, and then the staff kind of in the back, and it kind of looks something like that. It's pretty crazy. This patient was on 5 or 6 drips, had tele monitor inside, intubated at the front with the hyperbaric tech in the back, and then the ICU nurse here and the fellow just behind them. So you can see it's a tight space to get around and try and work around the patient, examine the patient is difficult. Oftentimes, if you're trying to listen to the patient, we will tell the operators to stop oxygen, because there's always constantly oxygen going in and going out to maintain temperature and pressure in there. So we'll tell them to shut off the gas so that we can listen, and then we resume. You have to check manual pressure sometimes, or if you have an A-line, you can get that set up. So in summary, critical care can be safely treated, can be safely administered to patients in hyperbaric environments. But to do this, you really need a chamber environment that supports it, specialized equipment that meets the NFPA guidelines, experienced staffing, and of the utmost, do no harm. So make sure that the risk-benefit is there for these patients. Just getting back to ventilators, knowing how they operate here on surface, it will be very important to translate it to see how they work down at depth. And this is a picture of Dan Popa, one of my coworkers at UCSD, and they actually had an iron lung like in the cafeteria over there. So in an ideal world, an ideal ventilator would have minimal electrical requirement. This is one of the arms of your fire triangle: oxygen, heat source, which is your electrical requirement, and then the fodder, or the fuel for the fire. You want to have ventilators that have low oxygen and bleed into the environment, because if you start contaminating in a multi-place center, pumping in more than 24% FiO2 into the oxygen into that chamber environment, the risk of fire goes incrementally up. You want a ventilator that's that has stable volumes and rate with pressure changes. You want to be able to have a ventilator that compensates for your gas density. Remember, as Boyle's law, pressure goes up, volume shrinks, your density goes up, and that makes your gas more difficult to breathe against. And in patients who are quite ill with significant lung compromise, be able to have a ventilator that provides high PEEP, high minute ventilation, and accurate volumes, especially if you're really targeting your 6 cc's per kilo. So some of the first ventilators were the non-electric ventilators. This is the Monahan 225. It's one of the oldest ones. It works on pneumatic principles. Very simple, no electronics, very low risk of fire, but it doesn't have too many advanced modes. This is an example of one of the ventilators from the 70s. It's essentially a, what I could gather from the literature, a pressure control ventilator. And so here you have your ventilating unit. Here it's designed by a system of bellows with an adjustable weight that you can slide the weight up and down to keep the springs to basically set your pressure. You can set it up to about 15 centimeters of pressure. And then your patient's here, and as you take a breath, the ventilator senses it, releases the pressure, and you deliver a pressure of 10 to 15 centimeters with your corresponding tidal volume. You exhale out, you have your PEEP valve there to maintain positive pressure during treatment. So some of the issues with these ventilators, though, the tidal volumes that you set at depth are not equivalent to the tidal volumes that are delivered to the patient when you're 45 feet under seawater. The volumes are much less. It requires constant adjustment at depth, and unfortunately, these non-electric ventilators are just not used as much anymore because you have better alternatives, and finding replacements and spare parts for them is becoming very difficult. So they're becoming more of just a museum now. The modern ventilators incorporate microprocessor, advanced displays, and alarms. I mean, you see it upstairs all the time. Typically, you can do battery-operated for the ventilator. Some chambers will allow for a feed-through, so you can pass the electrical supply out to outside the environment. You can typically do advanced modes of ventilation. They're more compact. But again, a lot of these modern ventilators still have problems with tidal volume and giving the volume that you want at a different pressure. And so these are the guys at UCSD. This is Dr. Watucki. He's the program director there, Dan and Jay Duchnik. They did an experiment using the Univent Eagle model. It's the standard ventilator that they use there. They tested different volumes at different atmospheres. So 1, 2.4, and 2.8, or sea level, 45 feet, and 60 feet of seawater. They used the Michigan test lung with a compliance of 0.05, set at 100%. What's interesting, I didn't know this until I came across it with him, is it's made in, this is the Michigan test lung. It's typically used for simulation of providing lung mechanics for doing research studies, of course. Made right here in Grand Rapids, so interesting fun fact. But they used it, and they delivered volumes from 100, 200, 300, 400, 500, all the way up to 700 cc's at the different atmospheres. Blue is sea level, and so you can see a nice correlation. You give 700 cc's at sea level, you get 700 cc's back. And then the red is 45 feet, green is 60 feet of seawater, and you can see a nice incremental decrease in the volumes exhaled versus volumes delivered by about a difference of about 100 cc's for your common ventilator settings between 400 and 500. And it's set at 12 breaths per minute. And when you're managing these vented patients with volume cycle ventilation, typically we take them off the ventilator on travel, so going in ascent and descent, descent and ascent, and you bag them on the way down. And then at depth, you try and set the volumes, and you have to actually measure the volumes. Here's this, like a little spirometer. The vent will deliver a breath, and you'll see what kind of breath comes out through the spirometer, and that will tell you, it's actually 300 versus 400 while at depth. But even these spirometers are not perfect. Dr. Weaver did another study looking at 2.9 atmospheres can be off up to about 6%. And this is compared to the gold standard, which is the Douglas bag collection with gasometer. Ultimately, you require a blood gas analysis to really measure your ventilation during hyperbaric treatments, looking at predominantly your pH and CO2. Just of note, you do have to tell the lab that, so they don't slow down the posting of results. You will get super physiologic doses of oxygen. Typically, we shoot for about 1,000 to 1,400. I've seen some as high as 1,800. Again, notifying the lab so that they don't remeasure and retest to make sure it's an accurate value is important. Power supply, easy strategy is batteries, but typically you need to include spare batteries. Usually it'll last for about 2 to 3 hours, but if you're doing your longer extended treatment tables, you'll need to send lock some new batteries into the chamber or have it with you there. You can do pass-throughs, but again, technically difficult when you're trying to bore a hole or have them, the technicians set up a hole through the chamber for which to pass through your plugs. So most centers use a conventional volume cycle ventilation, again, requiring constant manipulation during therapy. Dr. Protege from Maryland Shock Trauma did a study where his group hypothesized that pressure control ventilation would compensate for the changes in the atmosphere during treatments. And so what he did, he used, instead of the Michigan lung, he used a Servo 900 ventilator, and he used a dual Siemens test lung to simulate the human lung. He used a driving pressure about 22 centimeters, which generated a liter of tidal volume at sea level, inspiratory time of 1 second, 12 breaths. And he tested this condition at baseline, during the descent, 3 atmospheres, 6 atmospheres, which is different pressures, about 50 feet and 60 feet. 6 AT is like 165 feet, and then on the ascent. And he basically hooked them up to the ventilator before they started the treatments, and then measured the tidal volumes. And you could stay on this ventilator during ascent and descent without the need to disconnect and bag them on the way up or down. And respiratory rate, he found that the respiratory rate, exhale tidal volumes remained constant during all 5 test conditions. No adjustments were needed. This is an older paper I found in 2005. As of that time, he treated 9 patients or 25 treatments using pressure control ventilation with no untoward events. Again, as with anyone with pressure control ventilation, you have limitations in your lung compliance and the volumes that you're able to generate. So when you look at, in Europe, the CE, the CE certified ventilators, the CE is equivalent to the FDA in Europe. There's 2 certified ventilators that are used out there. The RCH Llama is a volumetric ventilator. Inspiratory flows are constant up to 6 ATA, anywhere from 3 to 21 liters. You can breathe them up to 35 with a IDE about 2. PEEP can only go up to about 10, and you can see some of the limitations there. What's interesting, this ventilator has a device that actually hooks up to the cuff of your ET tube and will adjust your cuff pressures as you're going through your treatments. 12-volt battery with audible and visual alarms. The Italian Ceratron is another ventilator. It's automatic compensation volume delivery up to 7 ATA. Very, very deep. We never really pressed to 7. Many different modes of operation, adjustable FiO2 and IDE ratios, a couple batteries, about 3 hours use time. In the U.S., we have one FDA-approved ventilator, the Atlantis. You can see it there. And these are all the specs of it. I mean, you can see it's basically ranges the whole gamut of what you would need on a ventilator. Works up to 6 ATA, 20 liters per minute for minute ventilation, up to 1.5 liters of tidal volume, up to 40 breaths per minute. Variable I times, E times, setting your IDE ratio, etc., and doing different modes of ventilation, CMV, IMV, PEEP, and PCV. What's interesting is that when you look across the U.S., there's probably like 15 or 20 ventilators that different hyperbaric outfits will use when they are pressing these patients. And so it's a little bit of a conundrum in the hyperbaric community. How can you use all these ventilators, which are not FDA approved, but you continue to use them? It's interesting. So the Navy actually looked into this, and they used the Penlon Oxford ventilator, which is certified for use in the Navy chambers, but in the early 80s, they stopped making that ventilator. They couldn't find the repair parts, and so they actually did studies on their own, looking at all the modern ventilators to see if it worked in the Navy hyperbaric chambers, because they wanted to keep pushing their Navy divers and be able to provide treatment to them if they were harmed by gas embolism, decompression sickness in whatever environment they were at. And so they ended up coming up with 4 ventilators that are approved by the Navy and used in the Navy chambers. The Univent Eagle is one of them. So there's 4, despite the one FDA approved, there's 4 other ones that the Navy uses. I think if it's good enough to use in the Navy, it's probably good enough to use in the hyperbaric chamber. But all those other ventilators that other people use have just stood the test of time. They've been using it for 20 to 30 years without any problems. So, just a few other kind of tidbits and considerations. Pressure, you always have to think of pressure volume changes. Your ET tube, the balloon, is another space of air. And so that as you're doing your treatments, one, you need to make sure it's well secured, because you're bringing a patient out of the ICU into the elevator, down onto gurneys and switching them, so you want to make sure it doesn't get dislodged. The balloon, as you descend, will shrink, and so you'll lose your pressure. And so you constantly have to add air into the balloon on the way down. On the way up, you need to keep a track of the pressure manometer of the balloon and actually let air out as you're coming up. Some institutions will fill the balloons with saline. Saline is liquid. It's a non-compressible substance, so it won't change in any shape during your treatments. UCSD used to do that. I think they had a Sentinel event where I think the water was, the saline was not removed all the way, and that ended up getting tracheal necrosis. And so they do all their balloons with air, adjustment of the air. Sedation is very important, of course, if they're intubated. Many different strategies, as you're aware, upstairs in the ICU. Typically, we'll continue with the ICU sedation, but beware that some medications, propofol, some of your vasodilators come in glass bottles. And so if you send them into the chamber, you can actually implode the glass bottle. So it's important to ventilate them. And so usually we'll stick a spinal needle up to communicate with the air and allow it to ventilate out, so that as the air in that little portion of the vial shrinks and expands, can pull air in or let air be released so that it doesn't crack the bottles. Neurongotomies, people disagree in the hyperbaric community about whether or not to prophylactically put ear tubes in these patients. People have their different views and theories about it, but at least UCSD, they do not routinely put tubes in intubated patients. Last thing is defibrillation. People undergo cardiac arrest. You want to know, can you defibrillate these patients? Of course, when you're shocking someone, there's risk of electrical discharge or creating an arc. Hence, increases your risk of fire. So it's definitely contraindicated in monoplace chambers where they fill the environment with 100% oxygen. You can only imagine 100% oxygen with a spark, not good. Actually, in a multiplace chamber, which I found out in the literature when I reviewed this, can defibrillate inside a multiplace chamber. And that's with multiple different safeguards in place. One, you have to make sure the air in that chamber is less than 21.5%. If any higher, of course, increased risk of fire. You need large adhesive plates to attach to the chest. Gel should be used for the conductive barrier. The area around the plates is free of flammable disease. The transmission cable has to be fed out through the chamber, so that the actual defibrillator is on the outside. The transmission cable has to be wide diameter, low resistance, to minimize any electrical discharges and such. And then again, the defibrillator on the outside. You need multiple people to operate this. One person to control the chamber, one person to control the defibrillator, and then one person to have their hand on the water deluge, so in case something does happen, you can basically spray the environment to minimize risk of fire. So far, we talked mostly about monoplaces. It's been a lot of the work by Dr. Weaver, but you can apply a lot of the same principles to multi-place environments. We talked mostly about multi-places, but you can ventilate, as Dr. Weaver does, in monoplace chambers. It's typically all the circuits are run through a pass-through inside the hull. You can see a little bypass bolts that they put into the chamber. For monoplace chambers, you have to fill the ET with saline because obviously you're not in there to regulate the air in the balloon. And typically you will probably need restraints in those people with monoplaces versus in the multiplace chambers, you have someone in there to help keep the patient calm. Thanks to Dr. Popa. We put this presentation together, and that's it.